Thank you. I want to thank the University of Toronto for organizing this presentation. Also, the MasterCard Foundation for partnering with U of T and a number of other institutions, mostly in Africa, in the context of the Africa Health Collaborative, to create a network that will help to strengthen public health in Africa. So the talk today is going to be about the role that mathematical modeling has played and continues to play in epidemic management. Within the Africa Health Collaborative, the African Institute for Mathematical Sciences is running a program on mathematical epidemiology, the goal of which is to train a new generation of mathematical epidemiologists that would support the management of epidemics on the continent. And we've had requests from partners, who want to understand what mathematical epidemiology is about, and so they can understand how they can work together with us to achieve their own objectives. So one of the aims of this of my talk is to give these partners some insight into what we are doing in our mathematical epidemiology program. Of course, those discussions have started, but I hope this presentation will contribute towards that. Also, I hope you would learn from this talk that while mathematical epidemiology is over 100 years old, so the application of maths to epidemiology has been going on for more than 100 years. It remains a field that's in its infancy. So there is a lot more that we need to do. There's a lot of further development in terms of the modeling, but also application of modeling to real-world problems. That needs to be done. And I'm hoping that young people, including those who train through the mathematical epidemiology program at AIMS, will help to make this contribution so that they can change the field, they can transform the field for the better. So when we talk of mathematical epidemiology, we're really talking models are central to it. So we'll start by looking at what models are. And then I'll talk in general how models are used in epidemiology. And then I'll describe a few case studies. The idea is not to present specific research problems or practical applications of maths to epidemiology in detail, but to give you some general ideas so you understand really the value that models hold for the management of epidemics. And because of how diverse I believe the audience is, I will keep the use of maths equations to the barest minimum. So you will not see many equations in this presentation. The hope is that the ideas would be clear through the illustrations that I'm going to present. So what are models? Models, when we talk about the model, it's a model of something we call the object of the model. So models are instances of concepts that allow us to know or recognize the object of the model, understand it, and also simulate and predict its behavior. Models are the basis of what we know about the world. So much of what we know about how the world works comes from our interpretation of the outputs of measurement processes. And so when we have a given output, we want to know how that relates to the inputs, the underlying inputs. Typically, it's the inputs that we want to know. And so the measurement process gives us outputs, often without any insight about the inputs. And it's in trying to understand these outputs, we want to know this mapping, to understand this mapping between inputs and outputs. And models are indispensable for this mapping process. In fact, there is a more fundamental way in which model appears in our daily lives. So imagine that you look at an object, you see the object. So what you are really seeing, what is happening is that photons that leave the object enter your retina, move to your brain, the signals go to your brain, and then your brain constructs a model of what is emitting these photons. And so this model, sometimes it's accurate. Well, often it's accurate, but sometimes it's not accurate. That's why you see different people can see different thing, the same thing differently. Sometimes you don't see things clearly, simply because this model, there is a deterioration of the fidelity of the model that is being produced in your brain. So models allow us to reason about the world in two general ways. There is the a posteriori or inductive ways, and these really rely on data. So you start by looking at the data, so the various complexes of facts that we gather through our senses, that's called experience. So we start from experience or from some data that we've gathered, and then we reason from that to answer questions, for example, like what was the generated mechanism of the data? Or if we play forward the process that generated the data, how would it look like? There's another way of looking at, of using models, which is for deductive reasoning. And this relies mostly on logic with just a bit of experience. Okay, so those are the two general ways in which models are used by humans. And these models can be implicit or explicit. So you can have mental images of something. I talked about the model that you can have of an object that resides in your brain. It's constructed by your brain. It's an implicit model. But you can also have a physical model, like an object. A car, the car I showed here, is a model of a real car. But there are other models that are equations, like the one here, which is a famous equation in physics called the Schrödinger equation. So we have these different kinds of models, implicit and explicit. And humans mostly use implicit models. So every human being is a modeler. In fact, there's a beautiful set of experiments that was published some time ago showing that showing evidence of the use of models in kids, in babies as young as 12 months old. So we all use models. Let's consider the following thought experiment. So imagine that you hold an apple up and then you release it. You're likely able to predict with a reasonable accuracy how quickly that apple will fall to the ground and also where it will hit the ground. And you're able to do this because you have in your mind a mental model of the way that gravity affects objects. But now, suppose that what you held in your hand is not an apple, but a feather, okay? How can you still predict how long it will take to hit the ground? And can you predict where on the ground it will hit? So this becomes more complicated. And so this shows that while implicit models are useful, they have limitations. To answer this kind of question, you really need to make the model explicit. You need to make the assumptions that underpin your implicit model explicit, and then you can perform computations on that explicit model to make predictions. And that such models we do have in physics, in particular models that are relevant to this particular question under consideration. So how are models used in epidemiology? I've shown here a working definition of epidemiology that I'm going to be using in this talk. So epidemiology is concerned with understanding and predicting the occurrence and causes of health and disease conditions in a given population, and also with identifying suitable interventions. So keep that in mind when I talk about epidemiology in the next slides. So in epidemiology, models are commonly applied to reason about health and disease in a posteriori fashion, so in an inductive fashion. So epidemiologists will collect data that are relevant to a question of interest, and then they try to work backwards to find the answer to that question. Occasionally, this involves fitting statistical models to the data, and so then the choice of models becomes dependent on the goodness of fit that you obtain to data. And the models that provide a good fit can then be used to address the questions, but also to make predictions about how the future might look like. There's a good example of this made possible by advances in machine learning. So now we know that for some flu seasons in the US, for example, by fitting models to historical data, these statistical or machine learning models, you can predict 1 week ahead of time the number of flu cases that will be recorded in a particular location in the US. And this is important for informing planning. So public health officials, for example, can increase hospital capacity in places where they expect large number of cases to occur. So these models are quite useful. Another way in which models are used is to reason a priori about epidemics. And the starting point is a set of assumptions that may or may not be based on data or experience. And then these assumptions are instantiated in a model, in an explicit model, which may be mechanical or mathematical in most cases. And then the model is used to investigate the logical consequences of the assumptions. And those consequences are then compared to reality to ascertain that we are really learning about the epidemics, we are learning about the processes that underpin epidemics. It's always important to go back, to refer back to data, to refer back to reality. This a priori modeling approach has the virtue that it allows reasoning to occur in a very general way. It is applicable even to novel health and disease conditions on which there's limited data. So, for example, the current case of Mpox, such modeling is very useful in terms of guiding the kinds of field assessments that people do and the kinds of interventions that they may make. In contrast to the a posteriori approach that I mentioned earlier, you mostly can apply it in cases where there is sufficient data about the health or disease condition of interest. So let's look at some examples. The first example I want to mention is a seminal example in the field of epidemiology. It's one of the first examples of the use of models to understand the dynamics of epidemics, to understand the factors that shape the spread of disease in a population. So the model is due to Reed and Frost. They were both scientists based at the Johns Hopkins University. And they built a model to answer the following two questions, among others. So what are the dynamics of a disease spreading in a given population, and what factors affect these dynamics? To address these questions, they built a model. This is an a priori model. They started with a set of assumptions, which I have listed here. So for example, they assume that infected individuals are infectious to susceptible individuals for a fixed period of time, that the infected individuals develop immunity lasting a fixed period of time as well, and each individual has a fixed probability of coming into contact with other individuals within one interval of time, and the susceptible individual acquires infection upon contact with an infected individual. Now, they instantiated this model in these assumptions in a mathematical model, but they were not satisfied with this mathematical instantiation of the model, in particular because it didn't account for stochastic effects, some random chance events that may affect the outcome of the interactions between infected, susceptible, immune individuals. And so to further investigate this, they constructed a mechanical model. Now, the mechanical model is as shown. This is Frost demonstrating the mechanical model in a class, in one of his classes. So he was using this also to teach students about how to use models to reason about epidemics. And so the model was constructed in the following way. He had a box with marbles, and the marbles, there are marbles with 4 different colors. So you had marbles that were red, those represented infected individuals. You had marbles that were green, those represented susceptible individuals. There were marbles that were blue, those represented immune individuals. And then marbles that were white, these were mostly boundary contact preventing maggots. Remember, in one of the assumptions, they said a susceptible individual acquires infection upon contact with an infectious individual. The white marbles were included to modify the probability of contact between individuals so that the probability is not always 1 at the start of the infection. So I'm going to explain what will be the consequence of not having white marbles in the milk. So they put these marbles in the box. This is on the right are curves generated from an experiment in which there were a total of 100 marbles in the box. Only one of the marbles was red, so one infected individual, simulating one infected individual. So you would shake this box to randomize basically the population of marbles, and then throw them into a trough. The trough was shaped in such a way that the marbles occurred on a line. So there was just a one-dimensional spatial arrangement of the marbles. So now he looked at this arrangement of marbles and said, okay, how many green marbles, so susceptible individuals, are in contact with a red marble, so an infected individual? If there are no white marbles, so the answer is going to be 2, right? If you start with one infected individual, typically, unless the infected individual is at the boundaries of the line, you would have on either side a susceptible individual. So now, once it counts the number of green marbles that are close to a red marble, that gives him the number of infected individuals within the population. The red marble becomes blue because in that time interval, in the time interval between each run of the experiment, he assumes that the infected individuals become immune. So you have, after the first run, you have, say, for example, 2 infected individuals, one immune individual, and the rest are susceptible. And then he plots this, and then runs this many times. So these are time periods, right? At each time step, he runs this experiment, and then plots the number of infected individuals he finds. He can also plot the number of immune individuals, the remaining number of susceptible individuals. Now you see, before each run, he puts back the marbles in the box and shakes them. So this is the randomization part of the experiment. So this introduces some level of variation or variability of the outcomes. And you can see on the right-hand side, these are curves from 3 independent experiments that he conducted in this way. In one of these experiments, there was no outbreak. So he went from 1 infected individual to 0. In 2 others, there was an outbreak, and the curve of the number of infected individuals follows the typical pattern that you see in an epidemic of this kind. So this shows how you can build models to try to understand the processes that shape epidemics. So this was a really instructive example. So despite its limitations, including the fact that the spatial arrangement of the marbles is limited, and hence the assumed spatial arrangement of the population is limited, is restricted, the model is a useful thinking tool for epidemiologists. It allows one to run computational experiments without the ethical issues associated with real-world experiments. And you can also use it to address questions of relations, directions, and interactions that underlie epidemics. For example, if you think a particular group is the principal driver of transmission of a particular disease within some population, you can ask what are the logical consequences of that? So how would the epidemic curve, for example, look if that particular group was solely responsible for the transmission that you're seeing in the population? And what would happen to the epidemic curve? What would happen to the epidemic if you targeted that particular group, say, for vaccination or for isolation in order to break transmission chains? So these are the kinds of questions, in fact, that we are currently asking in the context of Mpox. We have a team at AIMS that's working with partners in different parts of the world to ask these questions, and we are working in collaboration with public health officials in the DRC, particularly in South Kivu, and also in Burundi, to support them so they can reason better about the ongoing Mpox outbreak and come up with effective interventions that are also affordable. So this work is ongoing. I'm not going to say a lot more about that. Hopefully in the near future, we're going to have a presentation of the work. But I'm going to return to other aspects of the work that we are doing on Mpox in the DRC later in my talk. So the second example I want to present is that of Ronald Ross. Many of you would know Ross as a Nobel laureate. He won the Nobel Prize in Physiology of Medicine in 1902 for the discovery that malaria is transmitted by mosquitoes. Now, when Ross made this discovery, he thought that if mosquitoes are transmitting malaria, then by killing mosquitoes in the environment, by eliminating them, you could reduce the spread of malaria, so reduce the burden of malaria in the population. This proposal from Ross met a lot of criticism, and most of the people in the field at the time thought it would be a waste of resources and effort to try to use this approach as a means to control malaria. And their argument was that there will always be mosquitoes in the environment because you cannot completely eliminate them. And because there will always be mosquitoes in the environment, mosquitoes will always they will continue to transmit malaria to humans. So there will always be malaria in the human population. So it's pointless to try to kill mosquitoes in the environment. But there was a fallacy in this argument. And the main reason why his opponents didn't see the value, the truth in what he was saying is because they were not used to thinking in terms of numbers and dynamics. They were thinking qualitatively. You always have mosquitoes, so you always have malaria. So why control mosquitoes? But Ross, because he was not just a physician, he was also a mathematician. He was able to use models to clarify his thinking about this. And once he convinced himself, he decided to make a case to convince the community that this was a valuable strategy for controlling malaria. So I'm going to present some of Ross's models, focusing really on the essential ideas, not going into the details of the mathematics. So one of the things Ross first considered was the fact that if I have two environments, one has some interventions that are put in place to control the mosquito population. So that intervention is reducing the abundance of mosquitoes in the environment. Because mosquitoes move, they are not, they don't sit in one place, they are moving around, they're going to diffuse in such a way that mosquitoes that are in environments that don't yet have interventions will move into those neighboring environments that have interventions and become exposed to those interventions. So if you have, say, 5 environments, you don't necessarily have to have interventions in all 5 environments to reduce the abundance of mosquitoes in all of them. As long as mosquitoes are free to move around, you could target just one or a couple of environments and reduce the abundance of mosquitoes in all the environments. And this is a kind of thinking that is obvious to anyone who has thought about the process of diffusion. I think many of you in your chemistry classes in secondary school, you learned about how substances diffuse from regions of high concentration to regions of low concentration. This is essentially the same idea. And Ross was able to demonstrate that you, in fact, have this reduction of mosquito abundance in areas where you don't have any intervention. So then, after doing this, he then sought to link the abundance of mosquitoes to the risk of infection of humans. So he wanted to show that interventions could actually reduce the risk of infection. So thinking about probabilities, he came up with a simple model. The algebraic equation is as shown here. The different parameters are defined in this on this slide. So one thing I want to highlight is that Ross considered, so the product of B, M, I, and S gives you the probability that within the space of a month, an uninfected mosquito will become infectious to humans. Okay, so he was thinking about the processes that lead from mosquito and uninfected mosquito to the infection of humans. Okay, so the uninfected mosquito needs to bite an infected human, then the parasite needs to develop within the newly infected mosquito so that the mosquito becomes infectious to humans, and then that infectious mosquito has to bite a human. And the term below the slide gives you the number of newly infectious mosquitoes that then feed on people, that bite people. And that product gives you a risk of human infection by the mosquito. So basically what this is telling you is that if I reduce the abundance of mosquitoes, I reduce, for example, the um, the risk. I reduce the number of mosquitoes that can bite infected individuals. I reduce the number of mosquitoes that will become infectious to humans, and I reduce the risk of human infection by mosquitoes. So this is, in a nutshell, the reasoning aided by modeling that Ross applied to convince the community that they need to start interventions that reduce the burden, the abundance of mosquitoes in the environment as a way to control malaria. And today, this is commonly applied, but I hope through this brief discussion, you understand the history of this. Sometimes things that are obvious to us today, they didn't always begin that way. You needed someone to really think critically about them and put forward a convincing argument. And in this case, Ross was able to put forward a convincing argument bolstered by mathematical models. So the last example I want to discuss is the case of pool testing. So we have seen that models allow us to reason about epidemics in both inductive and deductive ways. Now, a posteriori reasoning uses data to generate insights, while a priori reasoning uses logic to generate insights, but those insights need to be confronted with data. So in both cases, the data are important. In particular, having sufficient data of sufficient quantity and quality is very important. But collecting this kind of data about epidemics is very expensive. So now I'm going to show you how models they don't only play the role of enabling humans to reason from data and about data, but also to collect better data so we can improve our reasoning and decision-making processes. So as an aside, I want to take a few moments to talk about what's currently happening with Mpox. So we face a really unfortunate situation in that we have a serious outbreak, which started in the DRC, the new variant of the Mpox. The first cases were recorded in the DRC. But up to today, we don't have data that's of sufficient quantity or quality to enable really effective decisions to be made. So it's unfortunate that a lot of the decisions that are being taken are not informed by an optimal quantity and quality of data. So there's a huge data gap. If you look online, for example, at what is reported, you'll see many in these data sets, a relatively small number of cases that have been confirmed, a large number of cases that are unconfirmed, that are suspected, okay? We cannot make effective decisions based solely on suspicions. And that is what public health officials are being forced to do because of the limited amount of quality data that are currently available on Mpox. So AIMS has not, we have been working to address this data gap since last year in an initiative started by this outstanding young man I'm showing here, Dr. Pacific Ndishimie, who is an AIMS fellow. Last year, following discussions with colleagues in the DRC, who sought assistance on interpreting some of the data that they were collecting, Pacific initiated a series of investigations that have enabled us to support the public health officials in South Kivu in their efforts to do surveillance for monkeypox, and also to make assessments about proposed interventions. Now, some of the things we've been doing include designing tools for surveillance. So earlier we saw the work we did in, I mentioned briefly, and I'm going to return to that, the work we did concerning the surveillance for COVID. We've been doing a similar thing, primarily designing primers for PCR tests using computational methods that we apply to molecular data. And then we have also set up a cohort study with the aim to follow infected individuals over a certain period of time to understand the natural history of Mpox, including in pregnant women. And the goal really is to provide data that will help inform effective decision-making by public health officials. We continue to develop additional tools for surveillance. And as I briefly mentioned earlier, we are also now using the data that have been collected in the context of a priori, the models useful for a priori reasoning to try to understand the transmission dynamics, and also to assess, for example, vaccination strategies. So monkeypox is an important problem. To address it, we need good quality data, and AIMS is trying to address this problem. Often we find that on the continent, problems like this, in the absence of young people like Pacific who take initiative, problems go unaddressed. And then our leaders beg for help from the West, from others for support, without saying exactly what we are doing to help solve our own problems and where exactly the support being sought can make a big difference. We need to change this kind of this approach to life on the continent. At AIMS, we believe that development cannot be imported into Africa. It happens through local initiative, the kind of initiative that Pacific took, and it's even better. It yields better results when this initiative is supported by international partners. And I want to highlight here a wonderful scientist called Trudy Lang at Oxford University, who has been supporting us to ensure that we set up this cohort study in the DRC. And now we are making plans to expand it also to the neighboring countries. So these are the kinds of things that we need to do more of in Africa. And we see AIMS as a portal, as a way to move the continent in the right direction. So now let me return to the issue of COVID data gaps. As early as March 2020, the government of Rwanda decided that in order to control the spread of COVID, following guidelines provided by the World Health Organization, they needed to identify cases within communities. So cases that are identified were isolated and their contacts were traced and quarantined. In this way, further spread of the disease was limited. And this was an excellent way to control COVID, but it was very expensive. So if we, to identify infected people, the gold standard is to do a PCR test. If we use a conservative estimate of the cost of the PCR test at the time, a PCR test for COVID, of $30 per person, millions of people had to be tested. So this was a huge cost that the country could not afford. So they had this excellent strategy in place, but implementation was problematic. And so they needed ways to test at a much lower cost. So maths actually gives us guidance on what to do in such cases. First of all, if I want to know what's the prevalence of a disease in a population, say I have a community with 1 million people, I don't need to test all 1 million people. If I sample the population well, I could test a smaller number of people and still know exactly to a very high degree of accuracy what's the prevalence of the disease in the entire population. But suppose I have a certain number of people that I want to test. In fact, I don't even need to test each of them, right? I don't need to test each one of them separately. There was an idea from someone called Ndifon some time ago, which is called generally described as pool testing. The idea is the following: say I have 9 people, I have sampled them from the community, and I want to find who among these 9 is infected. Suppose, let's assume for simplicity there is only 1 infected person among the 9. I can divide these people into groups. Now there are rules, mathematical rules for determining the number of groups into which these people should be divided, but we'll keep things simple. Assume I divide the 9 people into 3 groups, each of size 3. And so I take the sample from each person, each of the 9 people, and then for those who are in the same group, I pull their samples. So now I have 3 samples and I do only 3 tests. Okay? If I do these 3 tests, I will find that pool 2 is positive because it's the only pool that has an infected sample. So I take the 3 individuals who belong to that pool and I test each one of them. So this is the Ndifon idea. Basically, with 6 tests instead of 9, I can identify who is infected. There's a more general approach, which is optimal in terms of the number of tests that you can do. It's called a binary search, and it operates in a similar fashion, but a bit differently. I'm going through a number of sequential steps. So I hope you understand that with maths, you can both test few people and know what's the prevalence of a disease in a large population. And even the few people you're going to test, you don't need to test each one of them separately. You can use pooling to test, to do fewer tests than the number of people. Okay, so this results in cost savings. Now, the approach I just described, the one by Ndifon and the binary search approach, were not optimal for the situation that we faced in Rwanda in March 2020. So we decided to develop a new approach. And our approach is as follows. So imagine that you have a cube. Okay, here I show a cube, but it can be any high dimensional object that's regular, so a hypercube. Now I put my samples in the cube. If I have a cube like this, the cube has length L and dimensions D, right? So here D is 3, and let's assume for simplicity that my length is 3. So it means that in the cube there are 3 to the power 3 different cells, so 27 cells, which means I could put 27 samples up to 27 samples in my cube. Each sample occupies 1 cell. No cell is occupied by more than 1 cell. Okay? So I put 27 samples in my cube. So what do I do next? Now, the cube has 3 principal directions. Here I've shown one of the directions. Okay? So I have in each of these 27 cells a sample. What I do is I slice the cube L times. So in this case, we assume L is 3. So 3 times along each of its principal directions. I've illustrated how slicing is done along one of the dimensions. So this yields 3 slices, as you can see. Each slice is a square, and each square has 9 samples. So there are 3 squares or 3 slices, each with 9 samples. So altogether, I have my 27 samples. So what I do is I pull the 9 samples that belong to the same slice, and then I test. So I test, if I do the slicing along each of the 3 principal directions, I end up with 9 slices. And I test these 9 slices. So after testing, I identify the slices that are positive. Now, it so happens that the slices that are positive, they will all intersect at the location of the single positive sample. So after I do 9 tests, and then I label within my hypercube the slices that are positive, and I look at where they intersect, I identify exactly which sample was positive. So with 9 tests, 1 step, I'm done. So this is the essential idea of our approach to pool testing. And I want to say also, when you develop methods that you want to be applied in the field, you need to be able to study them rigorously to understand the optimal conditions for applying the methods, but also the failure modes. Under what conditions would it fail? What's the rate of failure? These things, this information is very important to guide the safe use of models in the field. So for our approach actually is accessible to this kind of analysis, and we've done that analysis, and I'll present later a paper that provides this information. So what's the advantage of hypercube testing for epidemic surveillance? When you are testing individuals, the disease continues to spread. So people who are in the community continue to spread the disease. And the spread, the prevalence of the disease in the community grows exponentially. So during COVID, for example, in China, the doubling time was estimated as to be 2.4 days. That's really short. So if it takes you a long time to test, it means while you are testing, the prevalence will be growing a lot. With the binary test, which is optimal in terms of the number of tests required, it takes log to the base 2 of 1 over the prevalence number of testing steps. And each step takes a few hours because of the time it takes to prepare material samples for PCR and to actually run the PCR test. So while you are doing this binary testing, the prevalence grows by a factor of 1 over p to the length of time it takes to do the test divided by the doubling time. So if it takes you 2.4 days, for example, to test, and the doubling time is 2.4 days, and your prevalence is say 1%, then by the time you are done doing the test, the prevalence would have increased by 100-fold. That's a huge increase. We can't afford to wait so long to complete a test, provide the results to public health officials so that they can make the right interventions. And so with hypercube testing, the waiting time for a test is very low. It's exactly how much time you need. It typically is just how much time you need to run the PCR. And so at low prevalence in particular, our hypercube testing method was preferred. This paper describes the method in detail. Now, let's take the example of Rwanda. So the GDP at the time was around $900, which equates to about $18 per person per week. Now, one COVID test, as I mentioned earlier, a conservative estimate was that it costs $30 per test. If you have a low prevalence and we test, say, we use pools of size 243 samples, then we can actually reduce the cost of each test, of testing each individual to 30 cents, so 100-fold reduction. And this cost falls as prevalence falls. Okay, and this is specific to the way our test works. In practice in Rwanda, groups of pools of sizes about 20 samples were used, and this nevertheless yielded large cost reductions, as you can see here. So this is plotted only up to February 2021, so 7th of February 2021, a time span of almost a year. It shows the number of tests across the various months per 1,000 people. And you can see that Rwanda was doing quite well. In fact, much better than the other countries in East Africa. And by the 7th of February 2021, the country had done about 800,000 tests. If they were paying, if this was being done at the rate of $30 per test, that would have cost 24 million. But the estimate is that it costs about 4 million, so about $5 per test, a six-fold reduction in the cost, saving the country more than about $20 million. And again, this is just up to 2021. Additional cost savings were accrued after that period, and that's not captured here. So what was the consequence of this intelligence strategy put in place by Rwanda and supported by models? The country had one of the best responses to COVID in the world. In fact, it was ranked by one of the Low Institute based in Australia. So for a summary, models we have seen, I hope you now understand, are indispensable for reasoning. And we can have either implicit or explicit models. Humans use implicit models all the time. Model-based reasoning happens both in a posteriori and a priori ways. A posteriori reasoning relies on past data, while a priori reasoning has less dependence on data. Models can provide useful guidance for epidemic management, and I showed the example of Ronald Ross, who used models to provide a justification for reducing the abundance of mosquitoes in the environment as a way to control, to reduce the burden of malaria. And models can also be used to devise ways to efficiently collect data on epidemics, as I showed in the case of Rwanda when responding to COVID. Thank you.